Good morning, everyone. We're certainly happy to have you join us today. Here at DO-Touch.NET Coordinating Center, we're a little short on people today. Both Brian Degenhart and Sarah Amini-Rod are out of the office today, so you only have Jeff and I to join you today. So my name's, for those of you who may not know me, my name's Jane Johnson. I am the Associate Director of DO-Touch.NET. I am happy to welcome you to this month's episode of Let's Talk About OMM Research. And this is our Journal Club episode. Before we begin, I'll just give you some housekeeping rules. So first, we would appreciate it if you would add your name and maybe your location into the chat. Send that to everyone or all panelists and attendees, depending on how it's worded on your screen, just so everyone can see who else is attending the webinar today. If you have registered for CME credit, you must add your name into the chat to verify your attendance. That's in place of your signing a piece of paper that you were here. So you have to verify your attendance in order to receive CME credit. Additionally, for those registered for CME, you'll need to complete the physician attestation form. A link was mailed to you for that, emailed to you for that this morning, and you'll need to complete the evaluation survey, which a link for that will be emailed to you this afternoon. And just to let you know that the Let's Talk About OMM Research Planning Committee, which consists of Brian Degenhart, myself, Jeffrey Allen Franklin, and Sarah Amini-Rod, we have no conflicts of interest to disclose. If you have any technical issues during the webinar, please send a message to all panelists in the chat. If you have questions or comments during the presentation, please feel free to type them into the Q&A pod. And please feel free to have a discussion in the Q&A pod. Interact with each other, address each other's questions, and make comments there. After the presentation, we will have time for questions, discussion, and questions. And we're hoping to have plenty of time this time. We have a history of running the presentation too long, and so we're working on that. So we're hoping to have plenty of time for discussion and questions. And if you would like to speak during the discussion time, please raise your hand, and we will promote you to be able to talk. We do ask that you briefly introduce yourself, just so people know who you are. And please feel free to turn on your camera if you'd like to, so we can see you. When contributing to the discussion, we would please ask you to limit your microphone time, at least for your initial, to 3 minutes. We want to allow, and Jeff will will give you a sign. He's our timekeeper. We ask that to allow everyone who wants to participate, to allow for time for everyone who wants to participate in the discussion. And so, as you saw, we have some flashcards to help you keep track of the time. And after everyone has had an opportunity to make comments or ask questions, there may be additional time for for comments or questions. Please keep in mind that this webinar recording will be placed on the DO-Touch.NET website, where you will have an opportunity to continue the discussion. So if we run out of time, we can continue the discussion in our discussion forums on the website. So watch for an email from DO-Touch.NET announcing when the recording and discussion forum are available. So we have a script to help us remember all of the things we're supposed to say, and it says, now please help us welcome Jane Johnson, the Associate Director of DO-Touch.NET, who will be presenting about this journal article. And hopefully you all have had a chance to read it. The article is entitled, oh darn, my scrolling is Osteopathic Manipulative Treatment in Individuals with Vertigo and Somatic Dysfunction, a randomized controlled comparative feasibility study. And so I'm going to forego my bio and just start the presentation. One thing I would appreciate, I will bring this up about my bio. Please remember that I am a statistician, not a clinician. So my journal club review here will focus mainly on the conclusions that I made based on this article from a research perspective. I would really appreciate your perspectives on the clinical implications of this journal article as well. So please feel free. I certainly hope that you are able to contribute to the discussion. So without further ado, let me share my screen here, and I will introduce this journal article to you. So this was research was done in California at the school in Pomona. Just to let you know, I have no financial relationships to disclose, and I won't be discussing any use of medications at all, off-label or investigational. Those are the learning objectives for the series. So we have I found an article, actually Brian Degenhart found this article about what needs to be in a journal club presentation. And so one of the things was basing on a case. And so I have a case here. I have a 90-year-old male who described unsteadiness and vertigo when turning his head. He has a history of surgical removal of cholesteatomas and removal of one eardrum. He also experiences periodic excessive production of earwax. And so I wondered, I wouldn't recommend, because I'm not a clinician, but I wondered whether I should suggest to him that he look into osteopathic manipulative treatment. So I did search for articles. I was looking for recent articles, and one I found was a systematic review by Tramontano and colleagues, and I did not have easy access to that article. I requested it from the library. I now have a copy. But this other article that we're reviewing today was open access in the Journal of Osteopathic Medicine. And so that's why we're focusing on it. Just a quick overview of the study. It's a prospective study. It was blinded, randomized, controlled, and it's a feasibility study. So the research questions for this study were, what is the effect of OMT in patients with vertigo? And their second research question is a randomized controlled trial comparing OMT and vestibular rehabilitation therapy feasible? So why is this important? So vertigo affects 15 to 20% of adults annually. There are negative effects on people's quality of life. There's increased risk of falls because of balance issues related to vertigo. And there is some evidence that it may be related to, that some vertigo at least may be related to somatic dysfunction of the cervical spine. So in this systematic review of OMT for vertigo and balance, they found a small number of studies, only 5. The quality of the studies was very heterogeneous. They were mostly small samples. They were all small sample sizes, and their recommendation was that randomized controlled trials are needed. And so the relevance of this study is to look at how feasible of the studies that we're examining today, how feasible is a randomized controlled trial comparing standard treatment, the VRT, and a no treatment control to OMT. So the methods. The inclusion criteria for the participants, ages 18 to 79, they'd had vertigo for greater than 3 months. You know, could they tolerate sitting, standing, manual therapy? They had to have the somatic dysfunction present, and an ENT confirmed diagnosis of peripheral vertigo that was not Meniere's. The exclusion criteria, they excluded many of these, like anticoagulation therapy and bleeding disorders, Meniere's disease, spinal trauma, cervical spine surgery, legal blindness in one or both eyes. And many of these would be confounding factors. And then if they had had any of the treatments under study with it, if they were undergoing any of those within currently or within the last 3 months, they were excluded. So the investigators decided on a 4-group study, a group that received OMT only, a group that received VRT only, a group that received both, and a group that received neither, which is their control. For those who received one or both active treatments, the treatment durations were 45 minutes weekly for 3 weeks. So the OMT treatment, they specified that the treating osteopathic physician would use counterstrain, myofascial release, balanced ligamentous tension, soft tissue, HVLA, and or articulatory. They excluded muscle energy because it is too similar to some of the VRT maneuvers. They didn't mention using cranial at all. And I would be interested in your thoughts about the exclusion of the muscle energy and not mentioning use of cranial. All of the treatments were provided by a single osteopathic physician who diagnosed somatic dysfunction and treated whatever somatic dysfunction they found with whichever of these treatments techniques that they chose. The VRT was the participants assigned to receive VRT received vestibular dysfunction specific exercises or maneuvers. And those were dependent on the cause of the vertigo. So those participants who had peripheral vestibular hypofunction received balance exercises. Those who had peripheral motion hypersensitivity received both balance and habituation exercises. And those who had vertigo that was benign paroxysmal positional vertigo received treatment, VRT treatment with the canalith repositioning maneuvers. Their outcome measures included a balance composition score, which was based on sensory organization test with computerized dynamic posturography. And they have a picture of that equipment in the article, that it has a harness and it's a balance board, which so it assesses balance or imbalance. The dizziness handicap inventory, which is a symptom inventory. So that assesses the severity of vertigo. And those were their primary outcome measures. They also assessed somatic dysfunction severity and did optometric evaluations. They measures these outcome measures pre-treatment and post-treatment. For the control group, that was 3 weeks after the baseline. And then they did a 3-month follow-up. So let's look at a little bit about some of the study validity. So one of the points that they make is that they randomize their subjects to the 4 groups, and they did a balanced randomization. And this is the strongest type of study as far as the evidence for causation. So can you say that OMT caused improvement in their vertigo? They did blinding of all of the evaluators of the outcome measures. So, for example, they had a DO that evaluated the somatic dysfunction severity that was independent of the osteopathic physician who provided the treatments, the OMT. They had a PT who did an evaluation that was independent of the PT who provided the VRT. And then the optometrist was also blinded to which group the participants were in. All of the researchers collecting any outcome measures were blinded, and those who provided the OMT and the VRT were blinded to whether the participants were receiving the other treatment or not. The study validity is improved by their use of both a clinical outcome measure and a patient-reported outcome measure. So they have an objective. This balanced composite score is an objective clinical outcome, and it has been validated, and a an 8-point or more change has been validated as a clinically important change in that balanced composite score. Similarly, with the dizziness handicap inventory, the patient-reported outcome, you're assessing the symptoms of vertigo, and that is also a validated scale with an 18-point clinic points as being determined to be a clinically important change. A few of the decreases to the study validity. This is a very small sample size. They had 26 participants total in the scale, in the study. But once again, this was designed as a feasibility study. That's their second question. Is it feasible to do this randomized controlled trial? They did have a fairly, for the sample size, they had a fair number of dropouts. They had 2 controls who dropped out and have no 3-week or 3-month data, and 1 dropout in the OMT only group with no 3-month data. And they excluded all 3 of those dropouts from all of the analyses. There was no assessment of whether there was any difference between the dropouts and those who stayed in the study. So we don't know if that impacted the study results or not. So the results, their age range was 29 to 67 years. 27% of the participants were men, and I focused on how many were men because of our case presentation. Okay, just 57% wore multifocal spectacle lenses, and the article does discuss the impact of visual issues that may impact vertigo. So for the patient-reported outcome, the dizziness handicap inventory, there were some statistically significant changes from pre-treatment to 3 months. The within group changes, in other words, from baseline to 3 months, the 3-month follow-up, the OMT and VRT, so the group that received both types of treatment, showed improvement. And the between group differences that were statistically significant were between the two groups that received VRT and the control. On the clinical outcome, the balanced composite score, there was a statistically significant improvement from baseline to 3 months in the combined OMT VRT group, but no between group differences were seen. As a reminder, these are very small sample sizes. So there's from a statistician point of view, there's low power to detect differences here. Okay. So if we look at back to our case study, would these results apply to a 94-year-old man? Well, it's really not certain. For one thing, the 94-year-old is well out of the range. It's even out of the range for the inclusion criteria, and well out of the range, almost 30 years out of the range for the ages of the participants. One of the most common causes of dizziness in the elderly are central vascular disease and cervical spondylosis, which we know certainly that the cervical spondylosis is one of the most common diagnoses for patients receiving OMT. The cause of the vertigo for this 94-year-old man is unknown. And even if we did know it, we don't specifically have information about the participants in this study about what the cause of their vertigo was either. Conclusions for OMM research. And this study does show that randomized controlled trial and this interdisciplinary randomized controlled trial is feasible. We don't know how long it took to recruit these 26 participants, and that is part of feasibility for a larger trial, in that, if it took several years just to get 26 people, then a larger trial might not be feasible. The authors did indicate that more funding than they had would be needed for participant recruitment and compensation. The reproducibility of the OMT and the VRT as well. We need more information about what somatic dysfunction was diagnosed, what OMT techniques were actually used, and once again, the causes of the vertigo. And then for this specific study, the generalizability of the OMT is not clear. since only one osteopathic physician provided all the OMT. Here are my evidence-based references. So I'd like to open this up to discussion for you all. If you have comments about the clinical relevance of this study and or the research relevance of this study. Okay, so I do see that Bill Brooks has put a couple of questions into the Q&A pod. One is, has the total severity scale for somatic dysfunction been validated in other studies? I do not believe it has. They used the SOAP note to assess the somatic dysfunction, and they described the severity score that they formed, but I do not believe that has been validated yet. But I will make sure I will look that up for you. I also see that Bill Brooks has put in, what criteria were used by the grading physician for any given judgment as to a finding judged to be somatic dysfunction? That information is not provided. Bill, when you say grading physician, you're talking about the person who evaluated the somatic dysfunction severity scale, I presume. And they didn't provide that information. So I see, maybe we can allow Bill Brooks to talk about.
Can you hear me now?
Yes. Hello, Bill.
Hi. Yeah, so it was either Dr. Redding or Dr. Ruby that one did the evaluation and one did the OMT, it appears, since they were acknowledged. And they're well known and prominent members of our OMT culture. But and I think this study is a significant step forward in research design, but at the core, we're interested in OMT. And so the relationship between all the various TART criteria, one to another, is not well described in our literature. The criteria for how we judge severity of any one of them is not well described in our literature, unless I simply don't know the literature well enough. And the other concern I have about this is that reliability is absolutely fundamental to validity. And this research would be significantly enhanced even in the absence of well-defined criteria for severity and the relationship between the various TART findings. It would be significantly enhanced if whoever it was, either Dr. Ruby or Dr. Redding, presumably, had intra-rater reliability established, because in the absence of all that, we're still just sort of shooting in the dark as to whether this is meaningful. So while the overall design, I believe, is a significant step forward for the profession, I think they've got to be careful about those pretty big holes in their design.
Absolutely. I agree with that completely, because there is evidence, plenty of evidence that reliability doesn't just of palpation, diagnostic palpation doesn't just come naturally, that it needs to be developed, and an assessment of that would be important. Thank you. Okay, so I see Amy Dean has her hand up.
Hi, everybody. Can you hear me?
Yeah, hi.
Hi. Hi. One thing I liked about this study was it kind of ties in with what Dr. Degenhart, I think, was talking about at the Convo Journal Club, that article by Dr. DeLongevin about interdisciplinary research, and kind of unsiloing ourselves, which I thought was, I'd like to see more of that, and I see when I work in the inpatient rehab unit, I get consulted for post-stroke vertigo, and it does seem to be quite effective. I'd say, probably 60-70% of the time, but it's also interdisciplinary because I'm working with the physical therapist and, the occupational therapist. So I wonder too, if that kind of interdisciplinary work kind of potentiates the osteopathic work, and my last thought was, Jane, what you had mentioned about the use of cranial, and I do think that's an incomplete study. I think that's a big hole in the study, because there's obviously a huge connection with, eighth cranial nerve and the temporal bone, and all kinds of stuff that can go wrong between the cervicals and that,
Right.
I'd like to see that. Yeah.
Yeah. Well, and I wasn't clear as Ronald Ellis stated, why wasn't cranial included? I don't have an answer for that. I think so. Some of our DO-Touch.NET members were involved with this study, and so perhaps I will write them and ask them if they could address that on our discussion forum about why they excluded cranial. I'm interested in your and anyone else's opinion about what impact do you think excluding muscle energy had as well.
I think you're right. Yeah. I think it did. I use that a lot in the hospital on the cervicals with the really chronic stuck stuff. I know there's kind of I don't know if this is everywhere, but a lot of inpatient providers seem to think that just treating the acute lesions is the way to go. But those chronic stuck lesions can cause so much pathology, whether it's vertigo or, any number of things. But that, and I think that muscle energy really can get that direct, kind of that direct barrier and start to mobilize that chronic stuff that's playing a role in patients' disease process. Is just my thought.
Yeah, I agree. Yeah. Okay. Thank you.
Thank you.
I see that Bill Devine has his hand up.
So good morning. Yeah,
Good morning.
I totally agree. Muscle energy actually is a neurologic treatment, and done properly, it actually takes down the inflammation of the facets, which generate a lot of it. Ciliary ganglion is really connected with the second cervical, and it goes directly on in the middle ear. As far as counterstrain, number of counterstrain points that we've published, including the clavicular division of the sternocleidomastoid muscle and its effect on dizziness is one of them. But the sternocleidomastoid, of course, attaches to the mastoid, affects the temporal bone. So using anterior for cervical, posterior C1, posterior C2, a number of points in the standardized study, all of the counterstrain and muscle energy techniques are reproducible, whereas some of us that do cranial manipulation may be a problem. Perhaps even doing a CV4 fourth ventricle treatment would have some variability among the examiners, but I've published in the past on muscle energy, for example, on Parkinson's patients. It's much easier to standardize muscle energy and certainly counterstrain. That's all I have to say.
Yeah. Well, Jeff's not getting a lot of work out here. Thank you. I find that fascinating that to think about the different techniques. I did wonder, we didn't see as big a change in the OMT only group as we did in the VRT group, and I did wonder if muscle energy at least had been included in the OMT as an option, whether we would have seen more change. And I don't know the answer to that. So I see that Stephen Gustafson put in the chat about whether study participants have peripheral vertigo or central vertigo. And then I think he answered his own question there. Yes, the participants had peripheral vertigo that was not Meniere's disease. So I see in Angelique Mazzara has put in there in the chat. I think when we promote more normalized physiological motion when performing any OMT, it allows optimization of all disciplines targeting improvement. Acute treatment hopefully prevents chronicity, but we do not live in a vacuum, and that's absolutely true. I think interdisciplinary treatment continues to increase, and to me that as an armchair osteopathic physician, I see that it has that interdisciplinary treatment is very osteopathic in its application. It fits with the osteopathic philosophy. So yeah. I do see in the Q&A pod, this is a significant step from Bill Brooks, a significant step forward in research design for OMM. However, the construct validity suffers by lack of information about inter-rater reliability for the physician judging somatic dysfunction. Yes, that is absolutely true. I also didn't want to bore you all with my assessment of the validity of the statistical methods used in the study. I believe they could have benefited from more robust statistical methodology. But once again, this is a feasibility study, and I think for them one of the most important points was to get the data to enable them to do a power analysis to determine what sample size they truly need. I see that Bill Brooks has his hand up again.
For future reference, please bore us with your statistical analysis.
Oh,
Because most of us, I certainly feel overwhelmed by statistics, especially the more complicated the study gets with 4 groups, et cetera. It gets really over our heads. So we have to rely on you, Jane, for real critical analysis of that. And while your comment is understandable, given that this is really a feasibility or pilot study, don't hesitate in the future to educate us and be robustly critical, because you know your expertise is really beyond certainly my head, and I suspect most of the other people participating.
well, thank you. Well, I will make a few, just a couple brief comments about that then. So the statistical analysis that they did, they did everything as paired tests. So for example, so they looked at each group by itself for within group changes. At, they compared the baseline to the post treatment. Then they also compared the baseline to the 3 months, and they also compared the post treatment to the 3 months. And so they're doing 3 statistical tests there in each of the 4 groups. So that's 12 statistical tests, where they could have done, which doing every statistical test that you do, the more you do, the more likely you are to have what's called a type 1 error, which means that you say that something is statistically significant when it really isn't. So in diagnostic testing language, it would be a false positive. And so the more statistical tests you do, the more likely you are to have false positive tests. And that wasn't the only test they did. So they did those 12 tests looking within groups. And then they used what they described as least squares regression modeling to compare between the groups. And they actually don't describe whether they assessed whether the statistical tests that they used, whether the data was appropriate for those statistical tests. There's something called a normal distribution. You've probably seen it. It's the bell-shaped curve, where most of the data falls within this middle section, but then sometimes you get outliers, and the further out you are from the middle, the less likely you are to have data out there. And the statistical tests that they used were based on assuming that the data was normally distributed, had that nice bell-shaped curve. And, potentially with the small sample sizes they had, perhaps they couldn't assess whether they met that condition of normality is the jargon for that. But there are statistical tests available that don't make that assumption. So you don't have to have this nice normally distributed data to use these other types of statistical tests. So there's your statistics lesson for today. How's that? Okay. Do we have any more questions or comments or discussion? Well, I'm seeing in the chat people saying nicely stated. So thank you. I appreciate that. Anyone else have anything to add to our discussion? Well, thank you. We might even end early this time. Thank you all for joining us. One thing I do want to make sure to emphasize to you. So starting next month, for our October 15th, let's talk about OMM research episode. We have a new time. We'll still be meeting starting next month. We'll still be meeting on the third Friday of each month, but our time will be 2 hours later than it is now. So it would be 12 p.m. Central Time. This time was selected based on responses to our survey of DO-Touch.NET membership. That was the time that came up with the most votes as being a more convenient time for people. And so we will be making sure that comes out. So put that on your calendar now, that for the next year at least, we'll be holding our Let's Talk About OMM research on the third Friday of every month at 12 p.m. Central Time. And so our next episode of Let's Talk About OMM research will be one of our network updates, and that's on October 15th. I really hope to see you all then, and I hope that's a convenient time for you. Thank you for joining us. We'll see you next month, and don't forget to join in the discussion on the discussion forums on the website. Thank you.